Boa tarde, pessoal. Meu nome é Silvio Henrique Barberato, eu sou diretor de comunicação da Sociedade Paranaense de Cardiologia e tenho a honra de moderar essa sessão a respeito dos casos clínicos e os desafios no combate à mortalidade cardiovascular ao redor do mundo, ao lado do meu colega aqui, o Dr. Gabriel Grossman, que é doutor em cardiologia pela Universidade Federal do Rio Grande do Sul, fellow em medicina nuclear e cardiologia nuclear na Emory University, presidente eleito do DERC 2020 e 2021, médico da clínica cardionuclear do Instituto de Cardiologia de Porto Alegre, chefe do serviço de medicina nuclear do Hospital Moinhos de Vento. Nós temos um tempo definido para cada representante de 12 minutos e acho que a gente teria direito a uma discussão, uma pergunta para cada um deles de 3 minutos. Então, para dar início, eu já vou chamar aqui o nosso primeiro palestrante, o Dr. Álvaro Vieira Moura, que é diretor da cardiologia intervencionista do Hospital Nossa Senhora das Graças e o Hospital do Rossio. O Dr. Álvaro vai nos apresentar, então, um caso clínico demonstrando os desafios que enfrentamos no Brasil.
Inicialmente, gostaria de agradecer à Sociedade Paranaense de Cardiologia pelo convite. Dr. Grossman e Dr. Silvio. Me pediram que eu fizesse a apresentação em inglês, então eu vou dando no início da apresentação em inglês e na continuidade os palestrantes falarão todos em inglês. So, we're going to talk about the clinical cases and challenges to fight cardiovascular disease, in this case in Brazil. And just to state the subject, we have like a mixed public health system in our country. We have a public system and a private system. The public system is responsible for more or less like 7% of the assistance of healthcare in our environment here. And the Ministry of Health took some action towards reduction of the mortality in our country with 2 ordinances basically. The first one is dated from 2011 regarding the acute myocardial infarction cases. And in the hospitalar phase, they release it for the public the use of tenecteplase, clopidogrel, and angioplasty in a more broader way. In 2014, in a pre-hospitalar phase, they took an action to release also tenecteplase for the mobile units. And this was something that followed an editorial at the New England Journal of Medicine from 2013. And what the editorial said is that now the main opportunity for improving outcomes lies in the pre-hospital systems of care. For you that don't know, our mortality rate is very high for infarction cases. We have like 9 to 10% mortality just in the hospitalar phase and during the first year of treatment. To understand what a hospitalar phase and a pre-hospitalar phase accomplish, we have to look to the guidelines. What the guidelines say is that you have 3 times here that are very important. First, the patient time. Secondly, the transport time. And thirdly, the door-to-balloon time. And they are marked by some things that happens when they are taking care of these patients. First is the symptom onset, when they start the symptoms. Then we have the first medical contact, so this will be like the patient time. The first medical contact to the transfer to a PCI-capable receiving center would be like the transport time. And from the PCI-capable receiver center to the primary PCI until you finish the angioplasty, you have the door-to-balloon time. And what we should be done is to accelerate the process the more you could, so that the first medical contact to your door-to-balloon time be below 90 minutes. And for us, what is important in the focus of this presentation will be that you have to reduce the pre-hospital system time that will be from the first medical contact until you receive the patients to a PCI-capable center. And one of the things that is very important is that the EKG should be done in at least 8 minutes from the arrival of the patient at the first medical contact, seeing the first doctor. So we started participation at the Latin program. And the Latin program was a broad program throughout South America and also Mexico. And the main objective of this program was to reduce the pre-hospital time by construction of a regional network of care where diagnosis would be made with telemedicine, a basic health unit training the physician at the basic care unit in our system, and giving priority transportation to the patient. So the acute myocardial infarction arrives should be the one that go first to the hospital, and to prepare the receptor hospital with designing protocols to to make it very quick the assistance for this patient. And I visit some of these basic care units, and what I saw is that most of them, the doctors that were assisting these patients were not even internal medicine doctors. They were gynecologists, pediatricians, so they didn't have enough prepared. They are not prepared to read an EKG in a proper way. So this is why telemedicine is important, because you do the EKG, you transfer by a Wi-Fi cable to another center. In this case was in Minas Gerais, and the answer to the EKG, the diagnosis was made in about 2 to 5 minutes only. So this was a Latin program. In Brazil, it started with 99 centers, and by the end of the program was enrolled by 143 centers. Also was done in Colombia, Mexico, and then Argentina and Chile. So this is the case. A female patient, 45 years old, that on July 24th of 2018 went to a basic unit at Campo Largo at 8:45 a.m. Her symptoms were the chest pain that started 1 hour from the arrival with one episode of syncope. Her blood pressure was very low, 70 systolic, 30 diastolic, was a previous smoker. The EKG diagnosis was done by telemedicine. Her arrival was very fast to the hospital. We arrived at 9:16 a.m. and went directly to the cath lab. What we saw there is the EKG was like a lateral infarction. This is how the EKG comes with the protocol. What we saw there is the ones that are not familiar with coronary angiography. This is the left coronary, and there was an occlusion at the left main. She had very, very few chances of survival of this, if not given her a very fast, very quick assistance. So we did like the PTCA of the left main. See how the flow is very slow to the other arteries, but now she has at least some flow. The EKG, the stent is in place at the left main and the LAD. Also an occlusion at the circumflex artery and an occlusion at the distal LAD. We did the PTCA at the circumflex with another stent, and a kissing balloon stent. Stent at the left main. Still some blockage at the level of the LAD, PTCA of the LAD, and then this was the final result. So see how the flow is much better now. The right coronary had no lesions at all. So fortunately she survived, and this is our hospital. It's the Rocio Hospital, is the region of Campo Largo. Is a big hospital. We have like around 1,000 beds, 250 units of intensive care units, and 50 is just related to heart conditions. And we have 3 cath labs. The emergency room is located at this area of the hospital. I'm sorry. It's here. The cath labs are very close to the coronary unit, to the emergency room. Our coronary unit is here. So with the right protocol, she was the time that she took to have to walk through the whole process was very, very short. We have like 1 hour, 1 hour and a half to have this artery open. So she survived. The Latin program in the Rocio Hospital had like 10 centers that refer to this hospital, to this area. The distance are different, and you see the orange line is the most, the one that is had the most time to arrive to the hospital, around 2 hours and 30, but this was done with facilitated PCI with tenecteplase also. By the end of the program, this program took like 5 years. We have done 97,000 EKGs, 853 EKGs had a diagnosis of acute myocardial infarction. They were transferred to the hospital. And our times are these. The Dodge balloon time was 27 minutes 36 seconds, the mean. The mean transportation time is high, is 120 minutes because of traffic, and some of the centers were a bit far away from where we are. And the first medical contact balloon time was around 2 hours and 26 minutes, is a little high, but we had like our mortality, in-hospital mortality was very low. And I think that the whole process, the whole process was the reason why the mortality was so low compared to what we have in our country. So we have like 20.1 mortality in the hospital, and in the country we have like 9 to 10%. So the difference is a big difference here. The conclusion is that the reduction of mortality caused by acute myocardial infarction is possible in our country, and this depends on the establishment of regional care networks that would include the rapid transfer of patients to structural hospitals. Thank you.
So we have 3 minutes for discussion. I don't know if one, from the audience. No? So I have a question for you. What do you think is the most important challenge to implement this program in Brazil?
For us, it would be an economical question, because this costs money, and we have a system that was paid by itself, but if you have to implement this to the whole country and making regional networks, small networks interconnected to assist all the patients, this will cost some money. This will be the immediate cost, but in 1 or 2 years would be paid so we have to convince the authorities that this would be a good thing to be done, because you will have more patients that will return with a quicker time toward their work, and you will not have most of the heart failure patients that you have without proper assistance. So we have just to convince the authorities that this is feasible and is economically viable by showing some numbers and showing the results.
Okay, thank you very much.
Okay, thank you.
So our next speaker is Dr. Andrew Einstein. I think that he's very well known from everybody, but he's a cardiologist and professor of medicine in Columbia University. He's an author of a lot of papers and book chapters. He's one of the most important physicians in our field. So please, Andrew, and thank you for your kind acceptance.
Thank you, Dr. Grossman. Pleasure to see you here in Brazil. I've seen you many times in the United States, so happy to see you in your home country. I'd like to present a clinical case demonstrating the challenges we in the United States face in cardiology. It's customary to show one's disclosures, at least in the United States, so these are my disclosures. You can see over the course of the past 70 years the dramatic reduction in cardiovascular disease mortality in the United States. There are many reasons for this and multifold reasons for this, some of which are illustrated here. Beginning with the identification in the 1960s through our Framingham Heart Study of multiple cardiovascular risk factors which have served as targets for risk factor reduction, the introduction of coronary bypass surgery, discovery of the low-density lipoprotein receptor in the United States, and the subsequent development of statins and their validation in clinical trials. Clinical trials in acute coronary syndrome, as we heard from the previous speaker, for example, from the TIMI group in the United States. Many advances which have led to this reduction in cardiovascular disease. Thus, it may be surprising to you all to see this recently published call to action, Urgent Challenges in Cardiovascular Disease, which comes from the president of the American Heart Association, together with recent directors of the Center for Medicare and Medicaid Services, our leading government payer for healthcare services, and from the Food and Drug Administration. Why is there a presidential advisory about these urgent challenges? I'd like to present a clinical case, then discuss why we have these challenges, and then return to that clinical case. Our patient, many similar patients of whom we see, is a 62-year-old male. He's a lawyer. His body mass index is 32, his heart rate 75, blood pressure 135/90. He's sedentary, has high stress from his job, he smokes, has dyslipidemia and impaired glucose tolerance. He was prescribed atorvastatin 40 milligrams, took it for 18 months, and now is non-adherent. He now presents for an executive physical examination after missing his last 2 physical examination appointments. And given his multiple risk factors, he was referred for a screening nuclear stress test. That screening nuclear stress test shows an inferior perfusion defect, which may represent diaphragmatic attenuation artifact. However, SCAR could not be excluded. So we face many challenges in the United States, which are outlined by this presidential advisory. I'd like to go through these challenges one by one and help you understand the big picture of cardiovascular disease prevention and treatment in the United States and why we may not be doing as well as we should be. Firstly, the decline in population mortality rates from cardiovascular disease is slowing. If you take a look at this same curve and look at the right side of the curve, that curve is really flattening. And in fact, age-adjusted cardiovascular disease mortality has slowed to about 0.5% annually, whereas cancer mortality rates have continued to decrease at a rate of about 1.5% annually. These have slowed for all races and ethnicities, and cardiovascular disease mortality has in fact increased in some groups and for some diseases. Specifically, here, for example, is cardiovascular cardiovascular disease mortality in rural middle age, that is age 45 to 54, white Americans. And the age-adjusted mortality rate from cardiovascular disease has increased from a nadir of about 94 to over about 104 over the course of the past decade. Similarly, age-adjusted heart failure mortality across the country. It was going down, and then things reached a nadir in about 2012, and it has modestly increased since then. Heart failure mortality, despite all these advanced heart failure treatments we have. Stroke mortality is increasing. If you take a look here, both deaths and age standardized rate increased from 2013 through 2015. If we look at data which is not on this graph from 2016 to 2017, stroke mortality increased by 1% at that time period as well. Risk factor profiles are worsening. Americans are not in good physical shape. In fact, about only 20% of Americans meet guidelines which our country establishes for physical activity. Most people are just not physically fit. We're sedentary, and we don't strengthen our muscles. Obesity is increasing dramatically. Nearly 40% of Americans are obese as defined by the World Heart Organization, and an additional 31% are overweight. So most Americans are obese and overweight. The percentage of Americans with diabetes has increased dramatically, and over 20 million Americans are living with diabetes at present. Moreover, there's large variation in mortality and outcomes with significant disparities between groups. In the United States, we perhaps artificially divide people between different races and ethnicities. And if you take a look at ischemic heart disease mortality in the United States, it's highest in Black Americans and lowest in Asians and Pacific Islanders. If you look at the ratio of heart disease mortality between blacks and whites, while that ratio was approximately 1 in the 1970s, it's now about 1.2. That is, blacks are about 20% more likely to die of heart disease. There's regional variation as well. Some states and some parts of the United States have higher heart disease death rates, and the disparity between blacks and whites is greater in some parts of the country. For example, in California, one of our two most populous states, blacks have a heart disease mortality rate in the highest quartile, whereas whites have it only in the second lowest quartile. Disparities across the nation. Cardiovascular drug innovation, which the United States has really pioneered, is lagging dramatically. Over the course of the past 20 years, the US FDA has approved 110 new compounds for cancer, only fundamentally 40 new compounds for cardiovascular disease. And things have slowed a lot in the past few years in particular. In 2016, our Food and Drug Administration approved 22 drugs. Only 2 of those were cardiovascular. One was a combination antihypertensive, nothing new there, and one was a combination of aspirin and omeprazole. Again, nothing novel there. 2017, one drug, it was the 4th in class factor 10A inhibitor, used in few patients for venous thromboembolism. It's basically a drug which nobody uses. 2018, 59 drugs approved by the FDA. One of them was an additional indication for rivaroxaban, which is a drug which had been using as well. The only new drug really is a drug for cardiac amyloidosis, which was approved this year, tafamidis. But for bread and butter coronary disease and atherosclerotic disease, the pipeline is not good. Perhaps the reason for this is the cost of doing the clinical trials. The average cost For a therapeutic agent in the cardiovascular space, $157 million. In the oncology space, $45 million. In the CNS space, $26 million. So these trials are just costing too much money to make it worth the while of big pharma to develop new cardiovascular drugs. And for that reason, the current pipeline is much smaller in cardiovascular diseases than it is in oncology. About 100 drugs under development now, most of which will never make it to market, whereas in cancer there are over 700 drugs in development. In fact, the spending on cardiovascular drug development in the United States has negative growth. We're spending less on developing new drugs despite the backlog in the pipeline. So we're just not making progress on that front. Yet costs are disproportionate to outcomes, and they continue to rise. If you take a look at this graph of health spending per capita versus gross domestic product, the United States is off the curve. We just spend too much for our gross domestic product, including on cardiovascular care, for which spending continues to rise. Yet this doesn't translate into life expectancy. If you compare the United States to other developed countries, we have lower life expectancy, notwithstanding the increase that we spend in comparison to other comparable countries. We miss opportunities at every step in prevention, diagnosis, and treatment. We fail to make risk factor modifications, which can reduce the odds of cardiovascular disease by 80% or even more, per the InterHeart study. We fail to elicit and follow people's goals and needs. We fail to diagnose. For example, 20 to 40% of heart attacks occur in undiagnosed cardiovascular disease patients. We fail to provide proven first-line treatments. As we've heard earlier in this meeting, non-adherence is a scourge. 40 to 70% of US patients are non-adherent to statins 1 year after prescribing them. We fail to use advanced treatments, and we fail to provide supportive care. So how does this relate to our patient? He's got multiple cardiac risk factors, which we failed to make risk factor modifications on. He's obese, he's a smoker, he's got impaired glucose tolerance, all things which can be worked on. Stress and his sedentary state can be worked on as well. His blood pressure, 135/90, this gentleman may well have undiagnosed hypertension. We failed to provide first-line treatments. He's missed his last 2 physician appointments, and he's non-adherent to his statin, which he should be taking. He's a high-risk patient. We failed to provide supportive care. This gentleman presenting for an executive physical examination, rather than having risk factor reduction, is referred for a screening nuclear stress test. The cardiologist will get reimbursed for this test in our fee-for-service model, but that's not what this asymptomatic individual needs. In fact, with his inferior perfusion defect, possible scar, he may well go for additional testing, including, say, a cardiac catheterization, where he really needs risk factor modification and counseling. So we have many challenges for cardiovascular disease prevention and treatment in the United States. We've been a world leader in many respects in cardiovascular disease, but the complacency has set in, and there are numerous challenges for us to move forward in the future. With that, I'd like to stop and return it to the moderators. Thank you for having me today. Obrigado.
So thank you, Andrew. One question from the audience? No questions? No? I have just one quick question for you. So we're failing a lot here. You just showed us that in one slide that you fail in every step that you could help. Why do you think that you are failing so much? What we can do to improve the outcomes and all these endpoints that you showed for us?
I think it's a multifactorial reasons why we're failing. I think the physicians' incentives are not aligned with patients' interests in many respects in our fee-for-service model, which really values performing procedures and not healthcare outcomes. I think there's creative thinking about that, but there's a lot of work to be done. I think education needs to start at a young age, and we're not teaching children enough about cardiovascular disease, the need for a healthy lifestyle. With the increase in wealth in the United States, it can facilitate unhealthy lifestyle behaviors. So I think these are some of the many factors which contribute to that failure.
Yeah, I have a comment, Andrew. Thank you very much for the case. I think you give us an opportunity to think that we don't have to spend more money. We can save some money. Perhaps the nuclear study that was done for this patient, which will make no difference for him, is not being done in another patient that would potentially save that patient's life. So this is one thing that I defend, which is strategy. We have to invest the money in an intelligent way, in a smart way, and do, I think, appropriate. We talked about this many times. Appropriate use criteria is helping us, and patient-centered imaging in this case.
Mm-hmm. In the United States, there have been many studies of appropriate use, and there's a lot of disparity there as well. We have centers. Rami Duki has published from his center or other centers in Chicago inappropriateness rates of up to 50%, but on average in the United States, about 1 in every 6 non-invasive imaging studies is rarely appropriate, and another 1 in 6 is only maybe appropriate. It's only 2 out of 3 studies which we're doing are appropriate. Yet there are, as you point out, patients who should be receiving these studies who fall out of the system and are not getting the care they need and the life-saving care they can need with this testing.
Absolutely. And when we look at, because this is an international meeting, if we look globally, we see so many developing countries where the patient goes from the treadmill to the cath lab, straight, without a filter to decide which patient would benefit the most from an invasive test. So inappropriate utilization of resources and technology is all over. Is in the cath lab, is on the exercise testing many times, is on nuclear, is on CT. So,
absolutely.
Yeah. All right. Thank you.
You're welcome.
Thank you very much.
Okay, let's keep moving. Our next presenter will be a professor from Belarus, Dr. Natalia Morozmaroz-Vadalazhskaya. I hope I said that right. Professor Natalia is a researcher focused especially in cardiovascular, acute and chronic cardiovascular disease and sports cardiology. He will be presenting a clinical case demonstrating the challenge we face in Belarus.
Boa tarde. First of all, I should say thank you, Dr. Giavitola, for invitation and including me in the program. We are so far, but I will show how it works. I will show the not differences, but similarities in Belarus and Brazil. We have the same, like in Brazil, many lakes, many rivers, but unfortunately we have not so huge waterfall as we could see in Iguazu. But our waterfall is a little bit slower, but we still have at least one. Yeah. And also we have many forests, with not so big trees, no palms, but our forest is beautiful, and if you will come to Belarus, you will enjoy. And I should say that if anybody tries to pass to Belarus, to come to Belarus and take flight, it will be possible without visa. So welcome. For at least 4 months, you can stay without visa, and no problem. And we have wild animals in public places. Fortunately, this animal, bison, like bison, artificially made, not real bison. Yeah, but we have some of them in the street and in city, and enjoy to be a part of nature as you are a part of nature in Brazil. And also we have beautiful flowers. This flower from left side of picture in my garden, and we enjoy nature as you enjoy it, and multicolor nature. And what was most exciting for me in Curitiba, just in front of my room in the hotel, I saw big building, big terracotta building with invisible sign close to sakura tree. If you will increase the possibility to view it, you will read Marc Chagall. Probably someone knows who is Marc Chagall.
It's a painter.
Yeah, Belarusian painter. So Brazilian, very close to Belarusian, and yeah.
Of course.
And his picture, this Marc Chagall and his pictures, very uncommon, non-classical, avant-gardistic, but he's a famous painter, originated from Belarus. It means not only imaging join us, but also some nature, history, art, and other. And in my case, about imaging and cooperation between any different kind of professionals, between cardiologists, surgeons, invasive cardiologists. This woman came to me for visit at age 69 years old. She is one of twins. And she was on dialysis, peritoneal dialysis, with end-stage heart failure. Renal failure. But she showed some typical signs of angina, Canadian class 2 or 3. And the treatment was not so effective because she had low blood pressure, and we cannot add any beta blockers or inhibitor, and we have many problems with the treatment and the correction of the drugs. She did peritoneal dialysis at home at least 3 times per day, by her hand, not without additional assistance or any care. And she did it accurately, but she had angina. And we cannot decide what to do with her, because nephrologists asked for renal transplantation, and they understood that angina is not good for this patient because of some complication during the transplantation. In my country, transplantation is very developed, or possibly not very, but developed. And we have, as you can see, at least everyday renal transplantation, also for children, liver transplantation a little bit less, and heart transplantation. 2 big centers can perform this transplantation, included in heart and liver and renal transplantation program. But the communication with cardiologist and cardiac center is not very close, and if some patient has, for example, angina, stable, not unstable, of course, stable angina, they refer to visit cardiologist, not heart team, but at least cardiologist. And this woman also should go to cardiologist at least for primary examination. Her ECG rest was absolutely normal, but a little bit bradycardic. She was a little bit bradycardic. Ejection fraction, normal, 52%. Slightly dilated right atrium and right ventricle we found during echo investigation, but with normal function, pump function. Stress echo was not done because of some discomfort during the cycling in this woman. Laboratory tests showed increased urea, creatinine, and glomerular filtration rate was lower than, of course, than normal because of end-stage renal failure, and it was approximately between 13, 14, and 15, 16. It depends on volume of dialysis. Cardiac enzymes were normal, and NT-proBNP protein was high at more than 2 to 1,000 nanogram per milliliter. What suggested cardiologist and transplantation center? They proposed to perform angiography without any stress test because the class of angina was 2 to 3, just the directly case for angiography, but really not. And as you can see, doesn't move. She had multivessel coronary artery disease, and cardiac surgeon asked for coronary artery bypass grafting in on-pump condition, open heart surgery. As every woman, as every person, this woman decided not to go roughly to surgery because she was quite stable and didn't want to be undergone open heart surgery for complication because complication score was quite high. And when we look at guidelines on myocardial revascularization, she didn't know about these guidelines, but her ejection fraction was normal, and multivessel disease that she had was not indicated as a CABG surgery. And she thought about mini-invasive approach to improve the coronary flow because she well-educated person, and she has many friends who are doctors, cardiologists, cardiosurgeons. But indeed, in transplant hospital, cardiosurgeon and heart team decided to perform open heart surgery. When she went to cardiologic center, heart team decided to find some not subtle but real reason for open heart surgery. If it is need, she should be undergone, but best to perform some functional test. Because transplant physician didn't think about it. And what is functional test could be performed? CT angio, because of renal failure, was not possible. Stress echo with dipyridamole, very long way, like dobutamine also, we could not find any good sign. We should shoot directly to target our aim. And we decided to perform SPECT. also stress, exercise, stress, SPECT, and unfortunately, the most important challenge in this case, in case of SPECT, SPECT was done by radiologists, not cardiologists, and this is a big problem to have good contact between radiologist and cardiologist, because radiologists represent only polar map of SPECT test, not pictures, not multicolor pictures, and cardiologists can only read polar map, not look at the side of ischemia and decide is it true or not. I tried to reconstruct some pictures, but these pictures not so clear, visible. Whereas ischemia really, it was a conclusion that ischemia in a LAD bed and the right coronary artery bed. And after consultation, like hard team, but not real hard team, that is also a challenge for us, we decided to perform PCI for this woman. PCI was held maybe 2 hours, because so many difficult places of stenosis, and also not only left coronary artery but right coronary artery. It was multiple stenting, multiple ballooning with good result. And what is now? Now she is 71. Last year she celebrated 70s. And she's walking in the garden, no symptom. I mean, no symptom of angina. She does dialysis, peritoneal dialysis, also 3 to 4 times per day, and doesn't want to go to cardiologist more than if it needed at least once per year. But she has many visits, not many, regular visit nephrologist for routine estimation of blood test and function, renal function. Obrigada.
Thank you, Dr. Natalia. I don't know if you have time for discussion, João. You are the boss, no? Because we need to we need to end 2:30 sharp because of the symposium. So unfortunately, we will keep discussion. So thank you very much, and we'll call Dr. Richard Underwood. He's professor of Royal Brompton Hospital and Imperial College of London, and he will tell us what's the most important challenges in the United Kingdom. Thank you very much.
Thank you very much, Dr. Grossman, Dr. Barberato. Pleasure to be here again with you in Curitiba, lovely city. And thanks to Dr. Vitola and also to Dr. Sersi for the invitation to be here in the program. Again, it's a great honor. I thought I would choose this case, and the subtext of the case is, can imaging overcome the oculostenotic reflex? Now, in case you're not familiar with the term oculostenotic reflex, it is a condition that some of my interventional colleagues have, and I'm sure some of your interventional colleagues have as well. You see a stenosis, and what do you do to it? You dilate it, because you can. And this is one of the challenges that we have, that often the oculostenotic reflex is not necessarily in the patient's best interest, and can imaging help us to avoid this? Am I pressing the right button? I am. Right. So let me introduce you to the patient. He's a most unusual patient. First of all, he's half the age of most of our patients. Our average age is 72 in our lab. He's also unusual because he works in the City of London, trading stocks and shares. He takes home more money in a day than you and I take home in a month. So he's been seen in the private sector in my country as opposed to the NHS sector, and I'll leave you to judge as we go through the case whether that has any influence on his care. Anyway, he presents with a 6-week history of left-sided chest pain. You speak to him. When did you get it? Oh, I got it in bed last night, but I got up and it went away. Do you ever get it if you exercise? Oh, I got it when I was walking the dog. Did it make you stop? No, it didn't really. I just carry on. So you get the idea that it's chest pain, but not necessarily typical of angina. You examine him, nothing to find. You take a resting ECG. There's his normal resting ECG, nothing to say about that. So am I allowed to be a little bit interactive? Can I ask some questions? So what would you do in this 36-year-old man with atypical chest pain?
Risk factors. Family.
No risk factors. No risk factors, and no family history of coronary disease. Who would do one? Which, in other words, no cardiac investigations. Go and see the gastroenterologist. That's your problem. Who would do that? Nobody's going to vote for that. Oh dear. Number 2, maybe he should have a CT scan. Okay, Dr. Vitola thinks he should have a CT scan. I think a lot of you are abstaining. You don't want to answer. Okay, who would do, let's go right to the bottom. Who would do an invasive coronary angiogram in this person? As people saying no. Okay, well, if you go to the guidelines, at least in my country, with the nice guideline body, but it would also fit with the European guidelines, would actually to tell you to do either 1 or 2. It would depend a little bit on what you judged his pretest likelihood of having coronary disease was going to be. And the reason, of course, for suggesting if you are going to do some cardiac investigations, CT, in this low likelihood patient, is that if you have a normal CT, you've done the right test. That is a good test to do. The problem with CT is if you have an abnormal test, you don't necessarily know if it's causing the patient's symptoms. So what happened to him? He actually did have a CT scan, but you didn't ask for it. He walked into your consulting room saying, I've paid my money, I'm rich, I've had my screening CT, or at least my coronary calcium score, which was 0. Well, I won't labor this point. What would you do next? Many people, I think, with 0 coronary calcium score would say, well, that puts you in an even lower likelihood category, and you should definitely do number 1 now. In other words, no further cardiac investigations. By the way, who would have done an exercise ECG in this person? Nobody? You would have done? Okay. Well, yes, you would have done, Andrew. All right, well, that is actually what happened. Although it would not be according to our guidelines. Our NICE guidelines say do not use a treadmill exercise ECG in this sort of a situation. But I'm just telling you real life. He did have an exercise ECG. He had no symptoms on the treadmill, but damn, he's got some minor 1 millimeter upsloping ST segment depression rapidly normalizing on recovery. The person reporting it said, I think this test is probably normal, but let me just check my medical insurance. So now we have a problem, don't we? Because we have a potentially abnormal test in this low likelihood young guy. What are we going to do?
Now a CT coronary.
Okay, well now you're certainly committed to doing something now, aren't you? I would suggest that since you've got one test that is a functional test that is equivocal, the correct thing to do is another functional test to try and say if that is normal or abnormal. But so that would be my answer, one of those two. But in fact, what happened was he had what you wanted. He had his CT scan. And I can't see so well from here, I'm sorry, but there's something going, can I get the pointer there? Something going on here in his LAD, isn't there? Can you see that? Who would say number 2, that's a stenosis in his LAD that's not functionally significant? Joao. looking closely. Who would say number 3? You don't know if it's functionally significant. There's a lot of, and some people are nodding. Thank you. Come on, be brave. Who would say it's a significant stenosis in his LAD? Okay, nobody. Oh, you're all very, very mild-mannered. Okay, well, congratulations to the gentleman there in the back row, because I think you should have said, I don't know. What test do you do if you want to know if an anatomical stenosis is functionally significant? You do a functional test. You don't look at an anatomical image and try to guess. Well, you can try to guess which it is, but I suggest if you want to answer that question, you should be doing a functional test. Anyway, there's something going on in his LAD, isn't there? So I would say that's the correct answer. I think now you're really committed to some more tests, aren't you? I would say you could probably do any of those. I don't think there's much in the way of guidance to help us choose there. Let me show you what happened. He actually had a perfusion scan. And what does it show? I think many of you who are used to looking at these things will be able to see that the stress polar plot shows a defect of perfusion in the anterior wall and apex, which normalizes at rest. So those of you who answered number 4, was it, to the previous question, you are right. But of course, now we have the evidence that it is functionally significant. What's the answer to that question? What happened next?
Coronary invasive coronary.
He had, you are absolutely right, sir, he had an invasive coronary angiogram. And I think I need to press a button to start this. Or am I able to do it? I don't think I can start it moving. It's moving. Perfect, thank you. So, I can't see well from this angle, but those of you who can see, I think we'll be able to see somewhere here. That is his LAD atheroma, isn't it? So that's exactly what was shown on the CT scan. What happened next?
Stent.
Okay, who would stent him? Oh, lots of hands going up. Who would say, he's got no symptoms, really?
36-year-old?
Yeah, 36-year-old?
Yeah.
Okay. So I think, can somebody press the right buttons? I think we need to start these videos. I apologize. But thank you. So there you are. There's the balloon in his LAD. And if you start the video on the right, you'll see it gives a good result. Okay? So you had your way. He had his LAD stent. What happened to his symptoms?
This is a tough question.
Can you guess? Nothing. No change. So here's the really important question. Did this patient benefit from the oculostenotic reflex? Okay? Now, I think I should probably end there. I don't know if we've got 2 minutes left even. I should end there because I'd really like to discuss that question.
So we have 2 minutes for discussion. And João will... Okay.
Richard, beautiful case. Multimodality, atypical presentation. I don't know if this patient benefits from the Revasc, but from the data you showed, we can be sure this is a high-risk patient. It's a young man, 36-year-old, obstructive disease, not only obstructive disease, but ischemic heart disease, all very well documented. So what therapy will benefit this patient? We'll see. We'll see the ischemia trial, which is one of the trials, looking for that information.
Joe, I bought these aspirins earlier today.
Aspirin, statins.
Because you gave us too much pink champagne last night. So I bought these aspirins. Maybe these aspirins would have done him just as much good as his PCI.
That should be on that person, not aspirin.
Great case, Richard. 2 points. Firstly, I think we would have approached this patient very differently at my institution. Depending on the pretest probability of disease, he would have either gotten just an exercise treadmill test or gone on, as I think NICE guidelines recommend, not for a calcium score, but rather for a coronary CT angiogram. The value of a calcium score in a symptomatic patient is really not well established. The value of a calcium score in an asymptomatic patient at age 36 without an extensive family history of dyslipidemia is not very valuable. This guy walked into a doc in a box, paid money, and got the wrong test. An almost worthless test for him. If you started off with that coronary CT angiogram, saw that lesion as your first test, you would have obviated the need to get the calcium score, to get the exercise treadmill test, and to get the nuclear test. When you saw that lesion of questionable functional significance, it's a long lesion. I'm worried about it, but in my institution, we're not sure that the data is so strong on this, but we would send this patient for FFRCT. We would package that CT scan, send it to the company which does FFRCT, and probably based on what you're showing me here, he would have had an FFRCT of less than 0.8. He would have gone on to the cath lab. So the fact that his symptoms weren't resolved, and this is my second point, doesn't mean he doesn't benefit for this. Identifying that this guy has such a burden of atheroma at such a young age, despite traditional risk factors, he's going to benefit a lot from the secondary prevention from that PCI. The statin and the aspirin are the best things you're going to do for this guy.
Okay, am I allowed just a final comment? Because I think there's some really important points there. I agree with everything you've said. I think, and I'm not pretending that route of investigation was the optimal. It's not what I would have done. I'm just presenting real life. But back to what João said, this is a high-risk patient, I think you said. Okay, what does high risk mean? A 5% annual event rate? 5, 10? Okay, so call it 10. So the point is this guy one of the 10 or is he one of the 90? And I put it to you that actually we do not have the tools at our disposal to be able to answer that question, because what we want to know is not what the population of such patients would do. We've got lots of data on that. We want to know what this individual will do. And in order to know that, we've got to know what the stability of that LAD plaque is. We've got some hints from CT, we can look at that, and intravascular ultrasound and OCT and things like that. But these are not really tools in everyday use. So I put it to you that I cannot personally answer that question because I do not have a test at my disposal to predict the stability of that lesion.
So,
And the nuclear data, looking at the perfusion, what's the patient's risk? Nuclear alone.
It's 5% per year, but that doesn't help us, does it? Because I'm a patient. I want to know if I'm 5 or if I'm 95.
Thank you, Richard, for your excellent case. Unfortunately, you're running out of time. Session's closed.